So the next question is, how do we get these things to patients? Because biomarker testing, I think, is going to be the biggest uh, bottleneck, at least initially, to getting these treatments to patients. Let's talk about why is it that we are so excited about these blood-based biomarkers? Why do they represent a transformation in clinical care? So I'm a dementia specialist, and I see patients on a weekly basis who are coming to see me with memory and thinking problems. And I would say that most patients presenting with cognitive issues, maybe 5% or less of them get biomarker testing, because the sentiment has been whether the test is positive or negative, it doesn't matter. It's not going to affect the management or the outcomes. But with drugs being available, that really changes everything. But this is going to be really hard because this is not how we've been practicing medicine for the past 20 years. And it's going to be really hard to do biomarker testing on the scale of people that are affected by Alzheimer's disease. So there's not really numbers available on this, but I would guess that clinical biomarker testing is performed in maybe 10,000, 20,000 people a year in the US, not very many. In my large dementia specialty group, we do 7 people a week typically, which is a lot compared to a lot of other centers. So what we're talking about is instead of doing 10 or 20,000 tests per year in the US, I think we really need to get to hundreds of thousands of tests. And how on earth are we going to do this? Amyloid PET is just not going to work. I've ordered one amyloid PET scan in the past 3 years because it costs $6,000 out of pocket. And it's, we just don't have the capacity of scanners. They're very expensive. They require highly trained personnel. And lumbar puncture. So I coordinate our lumbar puncture clinic, and it's a lot of work. Lumbar punctures are very well tolerated, but it is a very different matter than just sending someone to a lab. And so I think the only way we're going to get to the kind of scale of biomarker testing that we need is by doing blood-based biomarkers. Another issue that I think is important that sometimes isn't appreciated is that blood-based biomarkers may enable greater access to biomarker testing and therefore disease-modifying treatments for medically underserved or minoritized groups. And I can certainly tell you that there's evidence that these groups are not so excited about amyloid PET scans or spinal taps. And I think that one way we can help bring these drugs more broadly to the population is by using blood-based biomarkers instead of these other methods of testing. Also, something that we discuss a fair amount is that we should not make referral to a specialist contingent upon the results of the biomarker test. And one reason for that is that a lot of the patients that dementia specialists see don't have Alzheimer's. And so we don't want to close the door on anyone, close the dementia specialty door on anyone. But these tests can be helpful to better tell us who needs to see a dementia specialist. So what did we decide overall? And of course, there's more nuance to this that will be outlined in our manuscript. But we talked about how you would use blood-based biomarkers in what we call triaging. And what triaging means is you do a blood test, and then after the blood test, you have a second test, either CSF or amyloid PET that's more established. So you're using the blood test as a first step. So when using this in initial care, this would allow you to identify patients who are unlikely to have AD if they have a negative result, and to identify individuals who may be at high risk for having AD because of a positive result and benefit from a referral to secondary care. Now, in secondary care, like at the dementia specialty clinic, you can also use this to identify individuals who are unlikely to have Alzheimer's disease, so a negative result. And also to identify patients who are likely to have AD, a positive result, who you then go on to perform a confirmatory test on. One thing I would say about this triaging is, especially if you have a low pretest probability of the patient having AD. These triaging tests can really cut down on the number of referrals to a specialty care provider, which is really important because we're actually really inundated right now, and we need to be able to focus our resources on patients where they really need to see us.